Hello and welcome to OncoLife interview session. It's my pleasure to introduce our guest today, Dr. Jason Westin, Director of the Lymphoma Clinical Research Program and Section Chief of the Aggressive Lymphoma Research Team at the University of Texas MD Anderson Cancer Center. Thank you so much for joining us.
Thank you. It's my privilege to be here.
Today, we are talking about the Phase III SUNMO trial, which tested mosunetuzumab plus polatuzumab vedotin for transplant-ineligible relapsed or refractory large B-cell lymphoma. This chemo-free combination significantly improved progression-free survival and response rate compared to R-GemOx. Could we start with some information about your background, your professional journey?
Absolutely. I'm a professor of medical oncology at MD Anderson, where I've been for almost 20 years now, and have really enjoyed developing new medications, new treatments for patients dealing with lymphomas. I think that the SUNMO trial today that we'll talk about is a great example of taking targeted therapies and combining them with the ideal combination partner, and using that to move beyond the chemotherapy era into the targeted therapy era. So I'm excited to talk to you about the SUNMO trial today.
Could you share a brief overview of the current landscape for transplant-ineligible relapsed refractory large B-cell lymphoma, including the challenge patients face such as a time to therapy, toxicity, and access, and standard treatment for the options?
Yes. So thankfully, the majority of patients with large B-cell lymphoma are cured with their initial treatment, which is generally a treatment called R-CHOP or something similar to R-CHOP. The approximate 1/3 of patients who are not cured with frontline chemotherapy historically were treated with a high-intensity chemotherapy called stem cell transplant. But half or more of patients were not eligible to receive stem cell transplant because of the high rate of toxicities from giving a very intensive chemotherapy-based program. For that half of patients who are not eligible for stem cell transplant, often treatments were considered palliative or minimally effective, but not curative intent treatment. There are a number of treatments that are now approved for patients with relapsed disease, including tafasitamab with lenalidomide, some of the bispecific antibodies, including glofitamab and epcoritamab, and another antibody called loncastuximab. But these are often treatments that are helpful for a time, but not often curative or giving long-term benefit. And many of these are approved for third-line therapy, not necessarily for second-line therapy. So the options have been somewhat limited and not as aggressive as we would like them to be. And the advent of CAR T-cell therapy, which has been a breakthrough for many of our patients, has only had an impact in a relatively small percentage of patients. CAR T-cells are taking the patient's own immune cells, weaponizing them, and then using them against the cancer. This is generally for people that also would have been eligible for transplant. There are some patients who were borderline for transplant that would be eligible for CAR T-cell. But the reality is that in 2025, most patients don't have access to CAR T-cells. And so we desperately need more therapies for patients with relapsed refractory large B-cell, especially for those patients who are ineligible for autologous stem cell transplant.
SUNMO trial is the first positive Phase III study in this population without the conventional chemotherapy and showed 59 reduction in risk of the progression or death versus R-GemOx. What is the clinical significance of this effect size for the transplant-ineligible relapsed refractory large B-cell lymphoma, and how should clinicians interpret it alongside other active second-line options?
SUNMO is a global Phase III randomized clinical trial that compared mosunetuzumab with polatuzumab vedotin versus R-GemOx, gemcitabine oxaliplatin. GemOx has historically been one of the chemotherapy options commonly used around the world for patients who are transplant ineligible. And mosunetuzumab, polatuzumab vedotin, mosun-pola is a chemotherapy-free, conventionally chemotherapy-free combination that showed great promise in phase 2 trials. There's some synergy between these agents, which explains the rationale for using these. Mosunetuzumab was randomized 2-to-1, so 2 patients would get mosunetuzumab for every 1 patient that would get R-GemOx on this study. And as you mentioned, the primary endpoint showed a 59% reduction in the risk of progression or death, a highly significant finding favoring mosunetuzumab over R-GemOx. There were 2 primary endpoints on the study, overall response rate and progression-free survival. Both were very significant, favoring mosunetuzumab as a clearly superior regimen in terms of the effectiveness. But I think what's very important for that is that means that it effectively tripled the progression-free survival and it doubled the complete response rate, which means that the outcomes not only were statistically significant, but clinically meaningful. And so I do think that this will be a new option for patients using a regimen that is an antibody-drug conjugate and a bispecific antibody, not using conventional chemotherapy, but a truly novel therapy for patients with diffuse large B-cell lymphoma with a very manageable safety profile, which we'll talk about in the upcoming section of this interview.
How do T-cell engagers, mosunetuzumab, and anti-CD antibody-drug conjugate, polatuzumab, vedotin, work together, and why might this combination be effective for people with large B-cell lymphoma? Could you explain the mechanism and science behind it?
Absolutely. So mosunetuzumab is a bispecific antibody, and here bispecific, like bicycle, has 2 different parts. A bispecific antibody that has a binding domain for CD20 and CD3 effectively binds to a B cell, in this case a tumor B cell, and a T cell. And antibodies are not that large, and so it brings these 2 cells in close proximity. When the T cell is up close and personal with the malignant B cell, it recognizes it as a cancerous cell and it attacks and provides a potent cellular therapy off the shelf. This is something that's available in a bag. It does not require manufacturing in the way that a CAR T cell would. So bispecific antibodies, including mosunetuzumab, have this feature of bringing B cells and T cells very close. Polatuzumab vedotin is an antibody-drug conjugate targeting CD79B, which is a nearly ubiquitous antigen on the surface of B cells, part of the B cell receptor complex. Polatuzumab is approved for large B-cell lymphoma, both in the relapse setting as well as in the frontline setting. But what's unique in the SUNMO trial is that this combination of mosunetuzumab and polatuzumab vedotin was studied for the first time in a phase 3 clinical trial. And so the science behind this is basically it's a novel way of attacking the B cells twice. When polatuzumab binds to the B cell and directly delivers the antibody-drug conjugate toxin, it causes B cells to die, which stimulates the immune system, further causing an immune cascade that the bispecific antibodies feed into. So there is some synergy between these 2 agents, and we think that may be why this effective regimen was so potent in the SUNMO trial.
Subgroup analyses show a consistent progression-free survival benefits, including the patient with primary refractory diseases. Which clinical or biological subgroup do you think stand to benefit for most? And are there any phenotypes where a signal was less pronounced?
Yes, phase 3 trials always have an opportunity to look at the headline, but then you can always dig into the details to see were there any groups that appeared to do better or worse than others. On the SUNMO trial, the benefit favoring mosunetuzumab was consistent across all key subgroups. So if patients had primary refractory disease, meaning that they did not respond to either their first therapy or to their most recent therapy, both of those groups had a better response with mosunetuzumab than they did with R-GemOx. Patients with different subtypes of large B-cell lymphoma also had improved outcomes with mosunetuzumab, as did patients regardless of their age. So there was a consistent and clear trend for all subgroups to favor mosunetuzumab. and there were no key subgroups that were benefited more by R-GemOx. So it was clear across the board. This was not something that was driven by one group or two groups. It was a consistent trend that mosunetuzumab was superior to R-GemOx.
Could you share some also information on safety profile and adverse event of this regimen? How do you advise clinicians to manage stokin-release syndrome, stockopenias, and neutropenia in routine practice?
The SUNMO trial showed that the mosunetuzumab regimen was superior to R-GemOx, but of course it is a potent therapy that can have some side effects. However, the side effects were quite mild compared to what we might experience for other potent therapies with high response rates and significant improvements in survival. The main side effects that were different with mosunetuzumab included an injection site reaction. Mosun is a subcutaneous injection, so sometimes the skin can be irritated at the injection site, but this was not a limiting factor and patients could still receive their treatment. One of the common toxicities that we worry about for bispecific antibodies is something called cytokine release syndrome. This is seen with bispecific antibodies as well as CAR T-cell therapies. And it can be significant and limiting for some patients because some centers are not able to manage high-grade cytokine release syndrome, which can look almost like sepsis. Low-grade cytokine release syndrome can be a fever. And in the SUNMO trial, about 25% of patients that received mosunetuzumab did have cytokine release syndrome, but nearly all of those just had grade 1 CRS, which is a fever. So less than 5% of patients on this trial had anything more significant than a fever when it came to CRS. I think this will be very important for this regimen because it will allow this to be used in many different practice settings that currently do not use CAR T-cell therapy and currently do not use bispecific antibody therapy because of the difficulty managing high-grade toxicities. In the SUNMO trial, high-grade toxicities were just exceedingly rare when we talk about cytokine release syndrome. And so I do think this will be something that will allow this therapy to be much more broadly accessible to patients, which is clearly is a good thing.
Objective response rate and complete response rates improved significantly. ORR was 70%, CR 51%, and 73% of the complete responders remained in remission at 12 months. What do we know about the durability beyond this first year? And do you foresee the MRAD and ctDNA being incorporated to guide the treatment or surveillance?
Yes, the response rate was one of the primary endpoints of the study. There were two primary endpoints, and the first was overall response rate. And it showed a significant improvement over the chemotherapy regimen, a nearly 30% improvement in overall response rate and a doubling of the complete response rate. Patients treated with SUNMO, more than 50% achieved a complete response, which is notable for any treatment in patients with relapsed or refractory large B-cell lymphoma. But if it does not include a conventional chemotherapy and it has a favorable toxicity profile, it's even more attractive. But having a complete response is wonderful. The most important factor, though, is how durable is that complete response? Is this going to be transient, temporary, or is this something that will hold the test of time? SUNMO has nearly 2 years of follow-up, and what we can report is that the durability of the complete response appears to be markedly superior with the mosunetuzumab regimen when compared with patients who also had a complete response with R-GemOx. There were fewer patients that had a complete response with GemOx, but when we compare the two, complete responses appeared to be much more durable with mosunetuzumab, implying that that is not just a good response, but it's a deep and hopefully a response that is something that lasts for a long time. So, of course, additional follow-up will be needed to see the full outcome and how many patients can remain in remission long-term, but the response rates appear to be quite durable. With a high rate of patients who achieved a response and were keeping that response at 12 months and beyond. For the part of your question about MRD analyses, I think that the ability to test minimal residual disease will be something that's very important for patients with lymphoma in the years to come. At this point in my practice, it's not something that I utilize because I don't think the technologies have scaled to the point where something can be used outside of clinical trials. But I do think that will be important in the future, especially when choosing between different regimens and what treatments to give to our patients. I think the SUNMO trial will have additional data to look at for MRD analyses, but I would not advise clinicians to use that in their practice today.
Because of the regimen avoids conventional chemotherapy and hospitalization in most cases, could this broaden access across the geography, practice setting? What are the remaining barriers, like infusion capacity, toxicity management, that the system should plan for?
SUNMO is a fully outpatient regimen and does not require any mandatory hospitalizations. Mosun is given as a subcutaneous injection, polatuzumab is an IV, but they are deliverable in an outpatient setting that would not require a patient to have any time within the hospital, both for the infusion, the monitoring, and very unlikely to require hospitalization for toxicity management. Some regimens that may describe themselves to be outpatient, if they have a high rate of cytokine release syndrome or they have significant risk of toxicities, many of those patients will be admitted at a later time point to be observed for chemotherapy-related toxicities or treatment-related toxicities. But for SUNMO, the toxicities that might have required admission to the hospital could have included high-grade CRS. As mentioned, less than 5% of patients had any significant CRS on the SUNMO trial. So additional barriers that still remain, aside from the need for hospitalization for either monitoring or for toxicity management, would include regulatory approval. Obviously, this is a regimen that has great promise and looks wonderful in clinical trials. That has to still translate into regulatory approvals for this to be something that can scale and be accessible to patients around the globe. Management of toxicities is always something that takes a little bit of time when a regimen becomes available as a barrier. But because of the ease of use of this regimen and because how this will be something that is broadly accessible, I think that clinicians will quickly pick up the management of the adverse events, which are relatively modest, but still do require some attention from the treating physicians. But I think that the remaining barriers really are regulatory approval. And once that is hopefully secured, then this will be something that I think can scale and benefit patients today that don't have access to targeted therapies.
Looking ahead, what are the next steps for this combination, such as further studies, new patient group, early line use, and how do you see its role in evolving in the treatment landscape over the next few years?
Yeah, Mosun Pola was clearly superior in the SUNMO trial. And when something is clearly superior to an existing standard of care, it always raises questions of where might else it apply? Could it be superior to other things? We have a wonderful problem in developing drugs for large B-cell lymphoma, which is that there are a lot of new agents and a lot of very promising technologies that are coming along quickly. And so Mosun Pola is clearly superior in patients who are second line and beyond with transplant-ineligible large B-cell lymphoma. I think it's yet to be determined if there are other studies where this will be looked at in great detail to see if it could apply in the same way to other populations or other lines of treatment. But I'm very excited about it to be a regimen that hopefully is available for patients in the second line and beyond. The combination of antibody drug conjugate and bispecific antibody, I do think that this concept has great potential. And there are ongoing studies looking at a different bispecific antibody called glofitamab, which is also being combined with polatuzumab and chemotherapy in the frontline setting. The other antibody that's being looked at in this combination of antibody-drug conjugate would include epcoritamab plus polatuzumab in an R-CHOP-like regimen. And I think the future is very bright for combinations of bispecific antibodies and antibody-drug conjugates, perhaps not even including conventional chemotherapy for patients in frontline large B-cell lymphoma. So I think the future is bright for the combination of novel targeted treatments. As we begin to move from the chemotherapy era into the targeted therapy era, I think the future is very bright for our patients.